Hello, welcome everybody. We're going to get started here just in a second, but we have a lot of attendees joining right now, already over 500 and many more to come. And I'm really excited today for this Mount Rushmore panel on this very easy topic to talk about, post-exertional malaise. But let me just get started with a few housekeeping items. I wanted to share that the webinar will be recorded and it will be shared with all registrants, and it should be ready, a few days after we finish today. Questions can be submitted in the uh, a Q&A submission form, and we will answer those as many as we can at the end. Of course, nothing you hear today is direct medical advice. So, and it's for educational purposes. And you will hear the term PEM a lot today, and that means post-exertional malaise. And so when you hear us talk about PEM, that's what we're referring to. And I'm going to share an agenda right now in the chat um, for everyone to take a look at. Great. Then yes, let's get started with a few introductions. And so why don't we start with Dr. Bateman, and I'd love to hear just a little bit about what your role is in the space and what your connection to it is it slash how'd you get involved? How'd you end up here?
Sure. In around 1987, between 87 and 91, when I was doing my internal medicine residency, I got exposed to this illness. I was interested in HIV. And then, there was kind of this whole group of people, right, that seemed to have post-viral syndrome that wasn't HIV. And at the same time, I found out that my sister was suffering from this. So I got into the literature and started reading about it. And it was right when the first case definitions came out for chronic fatigue syndrome and fibromyalgia. So I was able to go to the literature, right, and really start to understand. It was right when there was interest in EPV. So since 2000, I've been exclusively a fatigue clinician. And that is, of course, narrowed to be almost all chronic fatigue syndrome. And we used to see a lot of fibro patients, but I think they have better access, and we've really tried to maintain access for the people who have the least access to medical care. And then we started a long COVID clinic in January of 2021.
Wow.
So I was active clinician. I'm in the last year or two, I'm kind of morphing to being more involved in our education and research and passing the baton a little bit in the clinic.
Wonderful. Well, thank you so much for having us today. Let's go to Dr. Putrino and then Curtin, and then I'll wrap up.
Sure. Hi, everyone. David Putrino. My clinical background is I'm trained as a physical therapist in Australia, and I have a PhD in neuroscience. I was happily being a neuroscience and neurorehabilitation researcher all the way through to 2020, where I was working with a lot of people with stroke, spinal cord injury, traumatic brain injury, ALS, conditions of that nature. And when COVID hit New York in 2020, my team built a fairly comprehensive monitoring program for people with acute COVID. And then as we started to monitor these acute COVID patients, we started to realize that some of them were not recovering. So that was really early in 2020, and we sounded the alarm and we said, something isn't right here. And we started to study at the time what we called post-acute COVID syndrome, because we didn't know what else to call it. And so we kept it simple. And then after we started researching this a little bit more, some folks from the ME/CFS world said, hey, you should study ME/CFS as well, because there's a lot of symptoms that overlap here. And then some folks from the Lyme disease world said, hey, we also have symptoms that are similar to this, and And so now we have a center at Mount Sinai, which is a hospital system in New York called the Cohen Center for Recovery from Complex Chronic Illness, where we study any illness that may be related to an infection where somebody failed to recover, an exposure to something like toxic mold or heavy metals, or some other sort of chemical or toxin where someone has failed to recover to their pre-exposure health status.
Amazing. Dr. Curtin.
Hi, everyone. So I'm Jennifer Curtin. I'm an internist by training, and I had ME/CFS for about 9 years, went into remission in 2019. And so I kind of went into this from personal experience, living through it. I've got dysautonomia, immune deficiency, I also have a genetic disorder. So I'm kind of a blend of, these different conditions. I'm hypermobile as well. So, I kind of got into it in part to say, like, all right, what's going on with me? And then also half my family was affected. And we went, as many of you guys probably have experienced, kind of the odyssey of going bouncing doctor to doctor. And, half of them tell you it's just in your head. The other ones are like, I don't know what's going on, but I'll work with you. And so I got well enough to go to med school. And so I was kind of getting worked up for all these conditions while I was going through my training. So it was interesting to be like a patient and clinician at the same time. And so I knew I wanted to work with this patient population ever since. And so I started out doing more like ME/CFS and learning about mast cell disorders, and then, the hypermobility syndromes and EDS. And then when COVID hit, basically I got together with a few folks because we were kind of going, oh man, if even a small fraction of people develop, symptoms that don't remit after this infection that's spreading across the entire world, this is going to be a disaster. And there's already, so few clinicians that work in this field or know about this. How can we try to, get this out to more people? And so I helped co-found Rhythm, and our clinic serves multiple states across the United States, and we're working to expand to more.
Wonderful. And yeah, my name is Charlie McCone. I have been a patient since 2020, and I started advocating later that year once I realized that may be my only chance of getting better one day. And through that process, I met the wonderful folks at the Patient-Led Research Collaborative, and I've since joined as a co-lead. And I'm still, I started out moderate, and my reinfection became severe, and I'm teetering between severe and moderate right now. And so I experienced post-exertional malaise. It's very difficult. And so I'm very excited for this conversation today with some of my favorite folks to talk about this. And so why don't we get started um, with our first question to Dr. Bateman, which is, what is post-exertional malaise and how do you define PEM?
Sure. So, I want to start by reminding everybody that PEM, it manifests differently in different people. And also the threshold for developing PEM varies in the same person. And the triggers may also define what the PEM symptoms are. So as you're listening, and if it doesn't sound like you or does sound like you, just be a little flexible, right, while we all share and talk about this. But the simple version is I consider PEM to be worsening illness from exceeding your energy envelope. And then as I was thinking here, I thought, if I really wanted to explain this, what words would I did? And I wrote this down. I said, I see PEM as increased symptoms and reduced function following damage or injury to the body that comes from using more energy than the physiology provides. And that's a combination of cellular energy capacity and also, I think, orthostatic intolerance related hypoperfusion. So it's kind of a double insult to the cells when we demand more from them than they're able to provide.
I love that. I think that's probably one of the best answers I've heard to that question. Dr. Putrino, what are the different terms for PEM? What is your preferred term? And a secondary question is, how does PEM differ and overlap with exercise intolerance?
Yeah, great questions. I mean, I think we do hear a lot of different acronyms and a lot of different phrases for this, so post-exertional malaise is probably the most common.
Yeah.
We hear about post-exertional symptom exacerbation. We hear about post-exertional neuroimmune exhaustion. And sometimes people would just say post-exertional symptoms, or something a little bit more simple in that regard. I do like things that are more inclusive, so I do prefer something like post-exertional symptoms. It's something that I find myself falling back to a lot, because I know that some people say, well, post-exertional symptom exacerbation doesn't really describe me because I get new symptoms when I push into PEM, or post-exertional malaise I don't like because I don't like this word malaise. It's too inexact for what I go, and so I do just like this idea of, and post-exertional neuroimmune exhaustion, no one really knows what you're talking about. So even though it may be the most accurate. So I do like things like post-exertional symptoms, just to say, if I exert myself, I may pay for it afterwards. And the PEM often gets sort of crossed over with other phenomenon as well. I think exercise intolerance is a big one. We often hear people, physicians who aren't familiar with PEM will often write down exercise intolerance. And I think, classically speaking, exercise intolerance is when somebody can't do the thing. So you say, hey, get on the treadmill and run, and they say, my lungs are burning, I can't do the thing. Now, people who experience PEM may also experience exercise intolerance, but they're distinct, because there are many people who experience PEM who can get on the treadmill and do the thing. They can run. It's just that they're going to pay for it, 24, 48, even 72 hours after they, as Cindy really nicely pointed out, sort of stress themselves beyond their energy envelope, push their mitochondria beyond what they should be pushing, and there we have it. So I think that that's what we've got to be careful with, disambiguating these terms. And I think fatigue is another one. You can have fatigue and you can have PEM, and you can have fatigue without PEM and PEM without fatigue.
Right. Excellent distinction. And yeah, really appreciate that clarification. Dr. Curtin, what are the different kinds of PEM? Most of us have heard of physical activity triggering PEM, but what else can trigger it?
Yeah, so there's many different triggers for PEM, and even just so cognitive load, so cognitive exertion, and that could be something as simple as having a conversation with somebody. Especially if the conversation requires any complex thinking or processing of more information, that can cause PEM. So some people refer to that as mental PEM or cognitive PEM. Also, I've seen PEM from sensory overload. So being exposed to too much sensory information, where it's kind of like overloading your system. And so a lot of times people will notice that if they were exposed to a lot of intense bright lights, sound, etc., that can actually bring on a PEM episode. And especially too, sometimes if sensory input is combined with another trigger, that can sort of make it worse, right? So it may be oh, my threshold for getting physical PEM from, let's say, activity or exertion of any kind. And that could even be as little as brushing your teeth or trying to sit up. For some people, it's even just trying to move. Others may be able to exercise, but they will then, as Dr. Putrino put, they may pay for it later. But let's say you combine that, your threshold's usually kind of around here, but let's say you're in a really loud atmosphere and there's a lot of light and sensory input. That may actually mean that you crash from that physical activity with the sensory input at a lower level. The other thing is that even emotional exertion can crash people too. And so that can be from something, even really positive experiences like socializing or hanging out with a close friend who you love, or even, just hanging out or going on a date. Something like that can even crash people as well. Because if you think about any kind of emotional involvement or something that was really, really like a very tough thing to go through, like let's say you got really bad news about, let's say a family member got sick or a beloved pet got injured, like that can also be a trigger.
Right.
And so there's many different things because all of these trigger our body to use energy, every single one of them. And so again, anything that can cause you to exceed that threshold of what our cells can actually make, you're going to end up here.
Okay, so this is prompting me an off-script question here that I'm going to go for is why do we think that is? Like why I get together with some of my long COVID friends recently, like, well, I can sit at a computer all day, but I can't brush my teeth. Or I can walk around the block a few times, but I can only sit at the computer for about 30 minutes. We all have different uh triggers and they all are at different thresholds and they're all kind of at different levels respectively. Does anyone want to, I know we're jumping into pathophysiology here a little bit, but like, does anybody have any pet theories around why this is? Please go, Lucinda or Dr.
Um,
Payton.
Two things I wanted to just kind of bring out. I think any physiologic stressor has the potential to cause PEM, but they don't all do it at the same degree. Exactly why that varies from person to person, I don't know. I mean, we left out things like immune and inflammatory triggers. Getting a virus can trigger it, right? Or having an immune event can trigger and sleep disruption. And I've had people had triggered from severe pain. So any kind of physiologic stressor has the potential to do it. I also think it's important, and this is more to your question, to
Right.
distinguish the difference between orthostatic symptoms and PEM. So let me tell you what I mean. If you get symptoms while you're upright, that's probably orthostatic. And that can happen when you're sitting at a desk, when you're standing, when you're anything where your upper body and especially if your lower body is also upright. And I think they're distinct. I think the symptoms of orthostatic intolerance can occur right while you're doing the activity. It can make you feel sick. If the orthostatic stress is severe and prolonged, it can cause PEM. So it can be a trigger for PEM as well. But I think sometimes we conflate the two. And just for my sanity, I separate them because I think they're different in the way we treat them.
Great. Does anybody else want to add on or dive in to the question anymore, or do we want to move on?
If you want some just wild conjecture, I'll throw my
I'm,
hat in the
I'm
ring.
here for it. I'm here for it.
Fantastic. I think I hear very similar stories to what you just said, Charlie, in that I think that like people uh people will have very specific PEM triggers, and I think that my pet theory for this is if we're considering a mitochondrial dysfunction role to somebody's PEM, um, it, it's probably fair to assume that your mitochondria across your entire body are not broken down. It's probably fair to assume that there are clusters of dysfunctioning mitochondria, and they may be responsible for certain organ systems, or they may be responsible for certain sensory perceptions, or they may be responsible for certain brain processes or brain functions. And when you're working those mitochondria, they're the ones who are sort of flooding your body with poison, creating the sort of reactive oxygen species in overload and not producing energy particularly well and switching over to anaerobic energy production very, very quickly. That would be my theory for why some people have such specific PEM triggers, um, and others don't.
And I'll kind of
I
jump in
like
on
that.
that. And I think a very similar way of thinking about this too is let's say you have residual infections. So talking about folks who have long COVID or folks who have chronic Lyme, depending on, especially if there tends to be some sort of tropism for where you have persistence, if there are viral reservoirs that are in certain target tissues, let's say it's,
Mhm.
it's in the bone marrow in your skull, like some of the studies have found, things like that. Or let's say it's in your gut, right? So then if that's kind of an area where basically your system is dysfunctional, you may have immune response to that. You may have something where there's ongoing inflammation and the system, the mitochondria maybe aren't working through because of ongoing inflammation. Then that could also just, as Dr. Putrino just said, lead to this sort of different thresholds for different things based on what is particularly impacted within your body with these different infections and where they're kind of hanging out.
Right. So what and where, could be explaining why we have different responses or different types of PEM. Since we're getting into pathophysiology, we're actually just real quickly, just to wrap this up, does somebody want to jump on, what is the concept of rolling PEM and or push crash cycles? The concept of, where our PEM doesn't seem to end, or it's accumulating, and or it's just in this nonstop vicious cycle and we don't quite reach, our baseline in a typical timeline fashion. I have this as an open question if anybody wants to jump on it.
Sure, I can take a little crack at it.
Sure,
And
Jen.
then
Yeah.
I guess Dr. Bateman sounds like you were about to, yeah. So I kind of think of it as, back when you have your cell phone and you tried to keep your old cell phone for a long time, and then eventually the battery just keeps draining super quick. And you're going, okay, why does my battery keep draining? I'm charging it, but then it drains super fast. And to me, I was enrolling PEM for my entire residency training. And basically you're kind of like, you're hitting your energy envelope every day and it's putting you, but I'm like just crossing it. And so I was in like a mild PEM crash when I would come home and I would just pass out. Sometimes I didn't even make it to my bed. It was just the couch. That was the closest thing to the door. And so it was like, all right. And then I would get up and have to repeat. And so it was like my system wasn't able to regenerate sufficient energy, kind of like, like I charged myself by sleeping, but then it just drains super fast the next day. And so I'm never able to fully recharge that battery and have it stick from day to day. So I'm like never fully out of the PEM flare or the crash before I start my next set of activity that then starts draining my battery again. And so that's kind of the thought analogy that I tend to use for kind of that push crash cycle.
Love how you broke that down. Does anybody else want to add anything to that?
I'll just add a couple of thoughts, and I think a lot depends on how severe your illness is and what stage of illness. But early in the illness, I believe that if you can stay out of PEM, you can be relatively symptom-free. You're just in a very small box, right? And can't do anything. And I totally agree with rolling PEM. And when we talk about physiology, I'll give you a little more about my insights and thoughts on that.
Okay, great. Why don't we jump into pathophysiology, and I'll go back to you, Dr. Bateman. So what is the conventional understanding or theories behind the pathophysiology of post-exertional malaise?
What I want to do is be institutional memory today. And I want to just really show you some early research that completely outlined my the way I think about PEM.
Please
If you'll
do.
just put up with me doing this for a minute. So this is a slide that just to quickly give you some background of this. We did this back in the 2000s. Our first paper was in 2009, so it's been a long time. And I worked with Alan and Kathy Light at the University of Utah. And we put people on an exercise bike for 25 minutes and measured these messenger RNA, this mRNA in the blood. And here's what's interesting about it is Al was a physiologist, a neurophysiologist, and he picked pain and fatigue sensory receptors, which are the first group. He picked adrenergic receptors, and then he picked some immune molecules and measured them. And what we did, just really quickly, is these are the controls. We measured all of these items at baseline. Then here's the exercise trigger right there. Then we drew people's blood 30 minutes later, 8 hours, 24, and 48 hours later. And you can see some elevations from the exercise that relate. But here's what happened when we did it in the ME/CFS patients. And this was a very small, I want to just tell you that this was a hand-picked group of 20 people that I knew very well, and I knew had post-exertional malaise. And these are fold increases, immediately measurable 30 minutes after the exercise trigger.
Wow.
And what really stood out to me about this, one is it's multi-system, right? It's immune, it's autonomic, it's neurologic. These receptors, the sensory receptors are in the dorsal horn neurons and are related to pain and fatigue transmission. But what makes me feel confident about these is these are all separate blood draws and separate analyses. And you can see that, and these are not symptoms, right? So most of these people did not develop symptoms until later. So the body is reacting immediately to the exercise. It's increasing at 8 hours and 24 hours. At 48 hours, it's still there, right? It has not resolved. So what I realized is if you exercise again at the beginning of 48 hours, right? Or the next day, you're stacking. This is like rolling PEM, right? You're stacking these chemical messengers that probably go on to create symptoms in your autonomic nervous system and inflammation and these other sensory markers. Just to finish this off, we did it in, I didn't do it, but Alan Light did it in a group of 9 MS patients who, and then when you look here, that purple thing is probably a lab error. This is really difficult assays to do. And actually they stopped doing this kind of tech for these messenger RNAs, for these biomarkers. But you can see the ones that are consistent, right, and show a pattern. And they also did it in, they had the controls exercise at high intensity. So you can see that at high intensity for 25 minutes, you start to bump these markers, right, at 24 and 48 hours, which is when you get sore after doing excessive exercise. So the reason I wanted to share that is it really shaped my my thinking.
Oh, you muted real quick.
Oh, you muted yourself.
Didn't mean to mute myself. I was trying to get my
Just when
screen
you
down.
just when you said shape my thinking.
Yep, it shaped, and my video went off. It shaped my thinking about how to counsel people. And basically I said, don't, and I'd show them this, and they say, don't raise your bars too high and wait till they come down before you do exercise again. And this just applies to the physical activity, but I've never forgotten it. It was not repeated. It was repeated later without the same clarity. And I think it's because there's so much heterogeneity, right? And it's hard to do these assays, but I have never forgotten it.
Wow. Yeah, that's an amazing graph. I've never seen that. And that's
It was published on the cover of the Journal of Pain.
wow. Love that. Thank you for sharing that. I really appreciate it. Dr. Putrino, what has some of the latest research told us about the pathophysiology of PEM, and what do you think is going on?
Yeah, I think there's been a lot of interesting research emerging that has been helping us to understand why people experience these, quite quite devastating symptoms after exerting themselves. I think some of the most exciting stuff right now is getting published by Rob Wust's group in the Netherlands and David Systrom's group at Harvard. I really think that it's interesting to see some of, and how some of these works, bind together. We're seeing that, Rob a couple years ago published this really interesting work in folks who had PEM regardless of diagnosis. He had folks with long COVID, he had folks with pre-2020 ME/CFS. They were allowed into the study so long as PEM was a symptom that they experienced. And he was able to show that during submaximal exercise, these plaques, these aggregates of amyloid, which is a protein that is a waste product that really it gets produced when we're producing energy, but usually our body is able to sort of clear it and get rid of it. But in this case, in folks who had PEM, when he looked at the muscle biopsy after submaximal exercise, he showed that there was sort of amyloid everywhere. The body was unable to sort of take out the trash in response to producing energy, which really, again, points us toward there's a waste clearance problem. He also has found this really interesting finding, which he's published in preprint. It's not yet gone to full publication, where he's looked at the basement membrane of capillaries that provide nutrients to muscle tissue. And what he's shown is that in people with PEM, basically that basement membrane, which is the thing that really allows nutrients to pass through the capillary into the cells that it's trying to sort of like supply with nutrients. He's shown that it's twice as thick, almost twice as thick in people with long COVID and ME/CFS compared to healthy controls. And actually, I still remember, being at a conference in Berlin and seeing this poster for the first time, because it was the greatest separation I've ever seen between healthy controls and people with PEM, where there was not a single dot, that represented a subject that was like overlapping into the healthy group or the PEM group. And so it starts to show us, okay, we've got an energy crisis with the mitochondria not working properly. We've got a vascular problem where nutrients can't make it out of the blood vessels into the tissue, into the cells. And then you have, upstream of that, you have David Systrom's work where he's showing he does invasive CPET. So he gets these folks exercising, with a catheter in their, in their heart, and he's measuring blood as it's coming out of the heart, which is crazy, but it is less crazy than it sounds, actually. But he's just technically brilliant and able to do these experiments, and he's showing, reduced oxygen extraction. So basically, the blood will travel around the person with PEM's body, but the person's not utilizing the oxygen. The oxygen's not being extracted from the blood. And so all of this leads to this very clear picture of when people are experiencing PEM, their mitochondria aren't getting the resources that they need. They're starting to misfire. They're starting to produce energy however they can, which also brings us to, some of the work that we've done in collaboration with groups like Renegade Research, where we showed that when people are in worse PEM, their lactic acid levels in their blood increase. Lactic acid is a waste product that mitochondria start to produce when they stop using oxygen to produce energy. And so, okay, they can't get it from, they can't get the oxygen out of the blood vessels. They're going to start producing energy without oxygen anaerobically, and then they start to produce lactic acid. So I think that that's, we're starting to understand what's going on physiologically. And it's starting to give us some really interesting clues around management and treatment.
Such a wonderful explanation from both of you there. Thank you. Dr. Curtin, anything else you would add to the biological underpinnings of PEM?
Yeah, so the basement membrane thickening, I remember there was a presentation in Cambridge at a conference. Dr. Hattis Tankisi, I think she's from Denmark. I may be wrong on the country, but she had some early stuff from long COVID folks, and she was saying on thickened basement membrane as well. And I believe they were noticing that there were a lot of platelets in there, on at least the ones she had found. They were going to follow up with a longer study, which I haven't really seen the results of yet. But so it makes so much sense, right? Where if your capillaries are too thick and you just can't get the oxygen across the diffusion's, pore, then you're going to be oxygen deprived in your tissues. You can't extract it. And then also you can't clear waste because it has to go back, the other way. And so, yeah, I think that basically like kind of a combination of like poor perfusion is also going to trigger to some degree like changes in things like how your immune system is responding, how your cells are producing energy, but also, are you going to actually have some sort of inflammatory response from this, especially as you start to accumulate waste products. And if your mitochondria are using less efficient methods for generating energy, Are they going to be generating a lot of reactive oxygen species? Are they going to be using and running you low on different metabolites, and other ones are going to start building up? And is that going to cause different cascades that can then have some of these downstream cascade effects that lead to some of these symptoms as well?
Right. And then so do we think, is the picture starting to show that PEM is one A to Z pathophysiology happening in different types, different parts of the body? Or do we think that there's different types of mechanisms that are producing PEM in folks? I'm curious if anybody wants to jump on that. Or, and it's fine if the answer is simply we just don't know right now and we can move on.
I think, we need better and more strict I think Cindy brought up a really great point about like disambiguating and differentiating orthostatic intolerance from PEM. I think we really need to get more and more strict about what we call PEM and what we don't call PEM. And then we can start to really tie in detailed pathophysiological mechanisms to the thing that we call PEM. And I think that biomarkers are really going to be an important piece of that puzzle.
Great. Let's move on to treatment and management. Dr. Bateman, what is pacing? How important is it to the management of PEM? And have you seen patients improve their baseline from pacing alone?
I would say pacing is right now, in the absence of better treatments, the most important intervention. And pacing to me means staying out of PEM, or at least reducing the frequency and severity and duration of your PEM, so that you don't raise your bars too high, right?
Right.
And you kind of wait till they come down. And I have seen people. I had one guy who didn't believe me about PEM. He just couldn't wrap his mind around it. He'd been an athlete and really smart guy, and I made a deal with him to stop everything for a month because he was so symptomatic. And he basically followed my instructions and all of his symptoms resolved. He wasn't doing anything, right? And then we worked on gradually adding it back and understanding how each factor might be triggering PEM. But the thing that's really, really challenging about pacing is it's not just physical activity, right? You have to understand what all the triggers are, and you have to reduce the severity and duration of exposure to those triggers. And sometimes there are many of them. And I think one of the reasons people don't know why they're in a crash or why they have PEM is because they're not taking into account what Dr. Curtin said, right? That, if you go out to dinner, you're having orthostatic stress, you've gone in your car, you're having all this noise and social interaction, and a whole bunch of things happen when you go out to dinner. It's not one stressor. And so and they add up, they're additive, and some of them are a little bit invisible. I will brag and probably overstate, but when I sit down and talk to someone, I can almost always tell them in a look back why they're in PEM or why they're in a crash, even if it wasn't really clear to them because they're right in the middle of all of it. But you go back and it's like, yep, there was that, then that, and that, and that, and all those things, added up to put you in that crash. So getting really good at it on your own, which is hard. I just wanted to give, just if you will permit me, I was reading,
Yeah.
I don't know if you know Zeest Khan. Zeest is a doctor who has long COVID, and she has a blog that is so wonderful. And I noticed the most recent one I got in my email, and it was on pacing. And I just took a little quote out of it. She said, the heart of the problem, I think, is we don't register pacing as work, much less hard work. That means we don't take pride in it, we don't celebrate it, we don't value it. My point is, you're not failing by pacing. You're acting in line with your needs, and you are working towards your goals. And I use the word work intentionally. Pacing is work. It's hard. It's one of the hardest things we ask people.
Absolutely. And I love how you frame that and the explanation there. Anything else? Or should we pass the baton?
We can pass the baton for now. I mean, the problem is there's so many triggers. right? And you can do some things to reduce those triggers and avoid those triggers. And that takes some skill and time. And that's a short answer for a complicated question.
Very good answer. Um, Dr. Curtin, have you seen, or what other lifestyle interventions have you seen help patients manage or improve their PEM?
I mean, definitely, obviously pacing, identifying triggers, reducing exposures to certain things. So sometimes like their environment plays a big role. So I've kind of noticed, especially folks who have an MCAS, like co-occurring component, like sometimes they'll notice that their PEM threshold is actually much lower in certain areas. Same thing with people who have like mold sensitivities and things like that, where if they're in like a moldier environment, they may notice their PEM thresholds lower. So the other thing I've noticed too is weather. So for instance, if barometric pressure shifts, I've noticed will seem to make people's crash threshold much lower. And so sometimes it's even things like just anticipating and like starting to understand, okay, this is just like high allergy season for me, looking at like pollen counts, mold air counts, looking at air quality, things like that, and starting to put together these patterns between like, all right, during these seasons, I crash a lot more easily. And so sometimes that means, you know what? Okay, PEM, your pacing actually has to like be even more intense during those times. Or, you know, sometimes this gets into the pharmaceutical aspect of we need to actually increase certain medications and things to help like counter some of that. Or some people who have the resources will sometimes be like, I'm just gonna go somewhere else for that part of the year. And sometimes that's true. And I've actually had people where they've moved permanently because they realized that they just felt so much better in other cities or other parts of the country where they didn't have as much weather variance, as much air quality and like mold spore and pollen and allergen variance. So, you know, I guess that's kind of one thing I can throw
Right.
in. Yeah.
Really great point. Dr. Putrino, what other lifestyle type interventions have you seen help patients with PEM improve their energy and or improve their energy envelope and reduce crashes?
Yeah, we've had some good responses, fairly comprehensive responses.
Yep.
You know, I liked hearing Jen talk about air quality index in one of our latest sort of data analyses with Visible, where that's one of the things that is popping as a very clear atmospheric driver of a crash is air quality index. And even we had a sort of an influx of patients calling us over the last 3 or 4 weeks when the Canadian fires were sort of bringing smoke over into New York, and that really seemed to set a lot of folks back quite significantly. So it really shows us that that can be a big driver. And I think, you know, it makes a ton of sense if it's affecting everything that we just spoke about with reduced oxygen extraction and
Right.
under-resourced mitochondria. If it's affecting oxygen exchange in your lungs, then you've got even less resources to play around with. So it does make good mechanistic sense to me, but it's a big one. The only other thing I think I could probably bring up that I haven't heard mentioned would be you know, we do find a lot of people we find really struggle with post-exertional malaise sometimes if they're eating certain foods. And I want to be clear, distinct from MCAS, we're not talking about an MCAS reaction, distinct from postprandial fatigue. We're not talking about dysautonomia. It's like, you know, it's a crash from the exertion of digestion. You know, it's often a surprising thing for some folks to hear about if this sounds like them, if this is a problem for them. Sometimes our dietitian, who's amazing, will work with them to just find like very easy bioavailable fuel for them. So, you know, there's sometimes like, look, you know, I eat so healthy and I'm, you know, kale and high fiber and this and that. And it's like, yeah, probably the most energetically intense thing that you can eat to digest because it's really hard to break that up in your stomach. And so, something that is just like white bread and, PB&J and, something that will give you a very quick energy hit with minimal difficulty for your body to break down, is often, you know, way better for some of these patients. So it's an interesting lifestyle management technique for a lot of patients that sometimes feels a little bit counterproductive or not surprising at the very least.
Great point. And definitely, yeah, I've seen that quite a bit in the community. Okay, let's move to PEM rescue and busters. And so when patients are in a crash, what are we looking at as the best intervention? And so we'll start with Dr. Bateman. What are your go-to treatments for patients who are in an existing PEM crash?
So I just want to tell you a little bit about a paper we published on PEM. It was in the ICFS journal, so it's not always easy for people to find, but we did an intense, complicated questionnaire to like 150 people. And what they all said that they used to recover from PEM was it was like a rest, sleep, limited stimulation, hydration were 40% of the answers. I had to talk about what PEM was in Recover. I was working in Recover clinical trials, and nobody had the concept of what PEM was, right? So I had to, for all the people designing the trials, I gave a talk, and I talked many times about PEM, and they were asking me questions, and I finally said, and I'm a fair-skinned person, I said, I think a PEM like getting sunburned, and there's not that much you can do about it. You can make it hurt less, right? But the skin is damaged. And it could be a little bit or medium amount or a lot. You could get, I've had third-degree burns, second-degree burns from sunburns. And you could end up with scarring, right? But there's not that much you can do once it's happened except support yourself. And I think they finally got that, right? Because they were saying, well, how do you cure it? What do you do? How do you fix it? And I think there's some things that we can do to treat severe symptoms once people are in a bad PEM, like help with pain or help with sleep, help them get through it without more triggers, right? But that's my attitude about PEM, and so you want to keep it so it's a mild sunburn, right? Or stay out of the sun and make sure your sunburn's only mild and can turn into a tan rather than peel off your whole arm.
And well, thank you for your answer and thank you for your service as well. It's greatly appreciated, as I'm sure many of us feel. Let's go to Dr. Putrino. What is your approach for people who are in an ongoing severe PEM crash?
Sorry, I'm still reeling in shock that Recover didn't understand PEM. No, Cindy, surely not. I love that analogy of sunburn. I'm stealing that. That's great.
It is.
That is really, really good. I think it is a really hard thing when someone really does slip into a prolonged crash that they can't seem to get out of. I mean, not to sound like a broken record, but like a lot of the time, the first thing that we want to start with is really, really, really making sure that the person is understanding you when you say rest. Because, often, I think both, Jen and Cindy have phrased this and framed this really, really well. The reason that you fall into these rolling crashes, it's not anyone's fault. Pacing is a sacrifice, pacing is hard, and sometimes life doesn't let up. Sometimes it's just like one thing after another thing after another thing. You can be laying in your bed and your mum's calling you about some crisis, or the cat is sick or whatever. And what are you going to do? Like you've got to deal with it. And so the first thing is really understanding if rest is occurring. and trying to counsel through that. And, you know, at the core, we have health coaches that can sometimes help with that, and just like, you know, managing the basic stuff well and making sure that that's really happening. And then, you know, if we're really sort of at a point where, hey, we need to do something, um, we're trying to do anything that we can to explore altering metabolic pathways. So this is where, you know, of course, we're going to be, you know, blasting people with as many antioxidants as we can. Where we're going to be trying to have conversations maybe about medications like metformin that can make things more bioavailable. And you know, this is the reason why also we're exploring low dose rapamycin as a treatment. We're not ready for it yet. You know, it's not ready for prime time in terms of thinking about it as, you know, as a Hail Mary for someone who's stuck in a PEM crash. But we're starting to understand more and more the benefits that mTOR inhibition can have for boosting mitochondrial function, especially if someone finds themselves in a sort of a cyclical crashing experience.
Great, additions there. Dr. Curtin, anything else you would add?
So I agree. I think, you know, definitely like radical rest, trigger avoidance, and that can be things like putting on noise canceling headphones. That can be things like reducing the light, wearing an eye mask. And that's kind of like the core base. I generally don't like to start new treatments for people when they're in a crash, just because sometimes if you react poorly to the new treatment, it could make your crash worse, right? Or it could prolong it. However, there's one treatment where if someone is in a really bad crash and it's prolonged, especially if they've got components of dysautonomia, they tend to be hypovolemic, they're not able to get a lot of oral hydration in. Hydration's a big key during PEM as well, and like hydrate, and also, yeah, try to eat if you can, just like easy to eat, easy to chew, digestible foods so that you don't get malnourished or during this period. And I know sometimes it's hard. You crash so bad you can't even make food for yourself. So it's like having a list of people that you can reach out to who will come and help you, or like kind of understanding like, all right, here's where I can DoorDash a peanut butter and jelly sandwich. Like having these things like prepared ahead just kind of helps you get through, because becoming malnourished during that, not having energy at all, can also be really tough. But one thing I will use is intravenous saline infusions, and there are groups that'll come to your home. The problem is that oftentimes they are cash pay services. It's very hard to get just like kind of as needed IV saline drips at home covered by insurance. It can be done, but it's usually for regular infusions and only if you meet certain criteria for like orthostatic hypotension and things. So I will use intravenous saline. The other thing I've been looking into recently, haven't started it yet because the sourcing is very challenging. Again, because of just access issues and what gets covered, what doesn't, the cost of things out of pocket, is IV amino acids. Just because at least on the ME/CFS, like the pre-COVID ME side, there's some data showing that basically the mitochondria, they're not really able to utilize certain types of energy. So they can't really utilize fatty acids and ketones and glucose all that well, but they're basically using amino acids to fuel their mitochondria, and it's a very inefficient process to do that. So if you can just kind of give them more of the fuel that they're using, then in theory, you know, we've talked to a couple of people who recommended that, who have a lot of familiarity with the ME research. But again, it's just, can you even get that to the person? The other one is dextromethorphan. So that's like a medication's often used for like, you know, cough, cold kind of things. And particularly if some people tolerate that well. I don't know if I would necessarily start it on someone if they've never taken it before. I wouldn't start it new on someone in a crash. What I would do is wait for them to come out of that crash and then try that intervention with them and see if they tolerate it well. And sometimes that can even help their PEM even outside of a crash. Like it can reduce their threshold a little bit, but make sure they tolerate it first. And then if they tolerate it well, then it's like, okay, that's another tool in the toolkit that you can then use if you do have another crash. And there's a few other ones, but you know, they kind of vary depending on what sort of crash they're in, what triggered it, and what they have tolerated before. Again, I want to emphasize, I don't like to start new things for people in crashes because there's a chance you could make it worse or prolong it.
Right. Dr. Bateman, I saw you raise your hand for a second.
Yeah, I'd love to add a little comment about dextromethorphan because we've been experimenting with that. I see it as a tool to prevent PEM. And the way we use it is I try not to give it to people all the time. I feel comfortable trying it because it's available over the counter, and the dose we use is really just the same as you would get if you were buying a cough syrup over the counter. But we have people get the 15 milligram capsules and take one before they go do an event that's likely to cause PEM. And then another one sometimes, the next dose when they come home. And I am absolutely convinced that it allows people to have a little, you can blow through it, right, if you try to do too much, but it allows a little more leeway in people before they develop PEM. And I kind of save it as a rescue or instead of giving it all the time. We don't really have data on long-term constant use. But so I'm just real conservative, but it's become a really great tool for people. And you know what? I think it works better in long COVID than ME/CFS, and it may be because of the pathophysiology of long COVID, or maybe because it's early onset disease. I'm not really sure, but interesting.
How often? So I'll just say disclaimer, that is one of the only drugs that has helped me with my PEM is dextromethorphan, and I use it for that purpose. If I'm going out, I'll take it beforehand, and when I get back, I'll usually take another one. And I'm also convinced it helps. Not doesn't cure it, doesn't solve it, but it definitely um, prevents, a more severe crash for me, or at least I believe so. How often do you feel comfortable prescribing it in the course of a month, a course of a week? Once a week, twice a week? I'm just curious.
I don't really give people a guideline. I just
Okay.
say don't take it on a running dose every day,
Right.
right? Multiple doses every day. We don't have very many tools. So
Yeah.
let this be a tool to help you when you've got to do something that's a little bit out of the ordinary. And I think I just let people kind of experiment on their own.
Great. All right. Well, let's move to Dr. Putrino with the big enchilada prevention. Um, what what are your go-to treatments for improving folks' baseline and preventing PEM, and what other treatments have you seen work? I know this is a big topic discussion, so we'll just get through it as best we can.
Yeah, I mean, I think that as always, what we're trying to do is make people as resilient as humanly possible to physiological stresses, and we've listed lots of physiological stresses. I'm kind of a bit of a broken record when we talk about some of the provider manuals that we've released out of the Cohen Center, and we talk about the different drivers that can cause, these sort of like physiological stresses that cause symptoms. And so I think, as we think about how, you know, immune dysregulation or viral persistence or pathogen reactivation can all put stress on your physiology that then ultimately leads into creating creating mitochondrial stress that leads to PEM. We're always just trying to think about how can we identify main drivers that are causing problems for people. How can we keep those under control? Of
Right.
course, all the regular stuff, pacing, understanding your boundaries, understanding your triggers. These are your sort of like baseline, most important tools. Then, taking the supplements that maybe work for you to support mitochondrial function. Like we often have, people who will tell us that things like, uh, you know, specific, you know, uh, probiotics that they use. Like there's one that we often work with called Venella, which breaks down uh, lactic acid and turns it into short chain fatty acids. They say, um, it doesn't give me more energy, but it makes me more resilient to PEM. Um, we hear similar things about people who have tried oxaloacetate and CoQ10, and um, supplements that can make them more resilient to physiological stresses that they can't anticipate in their day. So, I think about it as having a good foundation with all the lifestyle stuff, managing the drivers as well as you can, that can cause, additional physiological stress, and then having that layer of armor around you of what are the supplements that work for me to support my mitochondrial function, that can just give me a couple more, give me the ability to take a couple of unanticipated hits in my day that could knock me down.
Great. Um, and then and then you, of course, are targeting treatments to pharmaceutical treatments to the drivers you've identified.
Yeah, we're looking at pharmaceutical treatments. We're looking at various different biologics. We are slowly working our way toward uh, trialing mitochondrial transplantation in people with long COVID and ME/CFS. This is a
Wow.
interesting concept, where we can extract mitochondria from tissue in a person or in a maternal line relative, because we get our mitochondria from our mothers. Um,
Ah,
and then we can infuse, we can use a bioreactor to build up that tissue, get lots of mitochondria, and then infuse the mitochondria back into people. It's an involved process. It's pretty complicated. We have now successfully done it once in one patient. It was not a long COVID patient. We had to get FDA approval to try it in a less favorable risk benefit environment, meaning the person was a little bit sicker. But it was safe. It went very well, and we're now working toward making this available in a trial for folks with long COVID and ME/CFS. Because if even the situation is, hey, the mitochondria that you have just aren't producing enough energy, if we can just provide more mitochondria and do that on a biweekly basis, maybe maybe that is something that could really be helpful for a lot of people, even if it's just a band-aid, until we figure out the underlying processes.
incredibly fascinating, and exciting. And thank you for all of your work on that. Dr. Curtin, do you approach treatment differently based on the type of pen someone has? And if so, can you share some of the strategies you use or have used?
I do. So some things are kind of general blanket across, and many of them are what David mentioned and what Dr. Bateman has mentioned as well, like things like the pacing, making sure you understand your triggers, all of that, and some of these key supplements to support mitochondria. I have seen high-dose vitamin B1 be helpful in people. It doesn't help everyone, but there's a certain subset that I've seen like benefit, and that's kind of cheap and relatively safe. So I will use that a fair amount. One thing I did want to put in as well is the IV saline that I mentioned before for like a rescue during a crash. I do also have people use that before they go on, let's say they're going to be flying across the country, they're going on a trip. I'll have them get tanked up beforehand. And then I'll also have them find like wherever they're going to be landing within one day of landing, get another IV. And there's so many of these home IV infusion services now, they're everywhere. Like Drip Hydration has locations all over the country. If you just Google IV saline mobile, like you can find anyone in any city you go to at this point. They've kind of exploded. But in terms of, depending on what someone's PEM triggers are, so let's say, for instance, if someone has really significant cognitive triggers to PEM, sometimes I will look at things like, depending on what their age is, something like the Violite, or V-Lite. I always mispronounce that slightly, but that is a very expensive device. But something really cool that Renegade Research has done is they've created a device lending library, so people can access and try it first for a bit before they actually go and buy it to make sure it's actually helping them first. There are a couple other devices that people have found that sort of like mimic that a little bit, that are a little cheaper, but I can't say whether or not those like work the same. The other thing is I've noticed that some people for some reason respond to oxygen And so like having that around for folks is sometimes helpful. The other one is there's this rebreather device that's in trials in Canada. We've used it on about like 40 people in our clinic, and we've seen about a third of them have significant improvements in their cognitive ability to tolerate cognitive load. You have to do it very, very slowly, because just like I've used it myself actually, and it's a lot of work to breathe with this thing on. So you can trigger like physical PEM doing it. So you got to start real small and increase very, very slowly. But let's say for someone who maybe is a milder case and has the ability to tolerate a little more physical exertion, or let's say they're pure cognitive PEM. I've seen patients like that where they can do everything physical, but cognitive crashes them. I'll use the rebreather for them. And the other thing is injectable NAD, particularly subcutaneous. I've seen help. Some people use a nasal spray. I'm not really entirely sure like how much that really helps. And if they have a strong like MCAS component, sometimes intranasal cromolyn, I've seen sometimes help people as well. And you can kind of dose it around like when they're going to be cognitively exerting. The other one is oxaloacetate, can sometimes help with cognitive as well. I just know that, that one's expensive and not everybody tolerates it.
And do you treat, and what about physical PEM?
So physical PEM, I've noticed a lot of the like NAD, sometimes oxaloacetate for select people. Again, doesn't work on everyone. The high dose vitamin B1, IV saline. I have seen LDN work in some people for that as well. If they tend to have a dysautonomia type picture, really getting their autonomics stabilized. And that can be that depends on how their autonomics are dysregulated. So for instance, like, as Dr. Bateman was mentioning, right, there's a difference between like orthostatic, but if you push through the orthostatic stress, so let's say you're upright and you can't do this activity not upright, like it just doesn't work. Like you can't go to dinner lying down, right, and like eat, at a restaurant. So it's like, okay, I have to do this. So then it's like, okay, you're going to have that prolonged orthostatic stress. So that's where something like an IV saline would come in. Also things like, depending on what your autonomic distribution is, you may use things like beta blockers, especially if you're kind of more hyperadrenergic, something like gabardine. You may also use things like kind of like a very low dose of guanfacine in some cases. Not everyone tolerates guanfacine that well. Guanfacine can also be helpful sometimes for cognitive PEM as well, especially if there's overlapping ADD. Yeah, there's
Nice.
many more, but I mean, honestly, I could go on
Right.
forever because it's based on what your underlying kind of profile and picture is. Like, what do you have going on? If you're
Right.
hypercoagulable, there's different things. If you're highly MCAS, there's different things. So
Right. Let's go to Dr. Bateman, and then maybe we can do a cleanup round for other things, that have come to mind on this topic, because of course we could spend a whole hour on this topic alone. So Dr. Bateman, are there other treatments that have been mentioned that you use for attempting to improve folks' baseline and preventing PEM?
Yeah, I've been around a long time and gone down a lot of rabbit holes, so I've gotten more conservative because of all the things that end up not working very well over time. But
Totally. Yeah.
I really focus on the things that make people feel better in the short term also. So really working on and achieving the most restorative sleep possible, because of all the things that happen during sleep. And that's not easy, right? Because you can make things worse when you treat sleep. But you want to just work on it, I've got a whole lecture on sleep and you can't even cover it in an hour. And then sleep would be first. And the second for me is I'm enthusiastic about the impacts of orthostatic intolerance. I think people don't appreciate it enough and understand how it feeds in. And I think we could do better, right? And that's why we give people IVs. That's why we even timing your fluids before you go do things like, guzzling 500 cc's of fluids 15 minutes before you're about to be upright, and timing bolusing those fluids. And then, we really work on getting MCAS less active, so you're not constantly being re-exposed to those inflammatory molecules. And then this is a little tricky. Anything you can do to improve immune function and reduce the chance of viral reactivation. And that's very individual. We know that antivirals don't work for everybody, but some people when they're constantly reactivating their herpes viruses, it's one trigger after another. And there's an appropriate time to put people on antivirals or other immune modulating medications, and immune globulin and other things in specific cases. And whatever you can do to, reduce the triggers, right, that are likely will gradually increase your energy envelope. And then you just have to be careful, because I've even had people who could get their fitness doing a lot better, I hate to say that, right, because everybody's different, but who can work slowly on their muscle strength and their core body strength and really gradually improve it. But they can blow it out of the water pretty quickly, right, by having a crash. But I do think that reducing deconditioning over time is also not protective, but helps you function better, and to have fewer triggers. So it's really very individualized, right? And I think these questions will probably come up in a minute, but we don't have very good answers for when people go down and don't come back up, right?
Right.
And that's what we've got to understand a lot better.
Do you use any other immune modulators besides IVIG? Or is that the main
You
one?
want me to tell you what I use? It's old fashioned.
Sure.
We used to use intramuscular gamma globulin in
Oh, wow.
patients. It's pooled antibodies, right? It's hard to get now, and it's hard to get it paid for, but I still have patients who we maintain on that, and they kind of figure out the interval of how often they need to get their IM shot. And they kind of, with those borrowed antibodies, they're able to really it's different than IVIG. It's an immune modulator to get IVIG. To do the intramuscular gamma globulin is really borrowed immunity, that you just kind of keep your community acquired antibody levels higher. And so I'm not necessarily recommending it because it's hard to get, really hard to get. But
that's cool. Well, thank you for sharing that. Dr. Putrino, I saw you had your hand up for a second. If you want to jump back in with anything.
I'm just this is the dumbest thing, but I was just when Jen was talking about red light therapy,
Right.
just the little reminder that I always let people know of. Red light therapy has this biphasic approach, so more is not necessarily better. So don't do red light therapy every single day. You do it one day, you then give your body a day to recover, and then you can do it the next day. So like every 48 hours is what you want to go for.
Great. Well, yeah, does anybody else want to jump in on anything else before we go to some questions on different strategies or ideas for preventing PEM in folks?
Yeah, I mean, I'll kind of go in a little bit since we went into the IG route, but
Yeah.
looking for autoimmune causes of dysautonomia is super important, and just autoimmunity in general, and in all of these patient populations. We know in the long COVID population that, basically when you're acutely infected with COVID, you end up with non-germinal B cell formation, which is similar to what you see in lupus. So you can end up with a whole range of autoantibodies. And, one of the theories, right, is if you have some predisposition to autoimmunity to start with, let's say it's in your family, et cetera, you may not be able to rein in the autoimmunity after the acute infection has kind of tamped down a bit. So then you may have that now kicked off. I've seen many patients who've developed new onset autoimmune disorders after COVID, and managing and treating those is super important. I've seen people respond very well to subcutaneous immune globulin, IVIG, again, but challenging to get, very expensive therapy. I think some other folks, I've seen kind of mixed responses to stellate ganglion blocks, to be honest. Like some people seem to respond really, really well to them. And then others I've kind of seen like no response. And so it's just, we're kind of working on like, how do you predict? Because that's like it's an invasive, it's expensive. So it's like, how do you predict who's going to respond well? And for the folks who don't, is it just because they didn't have enough of them and you need a series? Or is it like you should be able to tell within one or two and you're good? So I think, there's a lot of different things that we've seen help people. But again, it is as both, Dave and Lucinda have said, like it is very, very, very personalized. You got to see what's going on in that person. Like, do you have spike protein still hanging out in your body? Then like, what do we do to try and like degrade that? what do we do if you've still got, trying antivirals? I had patients who had T cell responses positive to SARS-CoV-2 virus years after they were infected, and they also didn't have a recent vaccine. And interestingly, those patients tended to respond well to a combination of Pemgarda, Paxlovid. But again, trying to get those treatments can also be challenging. So it's sort of like this, you got to like go through the space to figure out what's going on in your body and then target the treatments to that. But I've seen a lot of things help. It's just, again, highly personalized. There are some general things that seem to kind of work across a decent number of folks, but I've never seen any treatment work in more than maybe like a really good treatment's like 60% or something. That's like, whoa,
Right.
most of the things I see kind of work in like maybe 30% or 20% or something. And so you really have to try to like figure out who's in that 30%, who's in that 20%. So that you're not just kind of having a bunch of people try stuff, but that is just kind of still where we are to some degree.
Great. Well, I'll wrap up with plugging all three of the respective institutions that people are everyone's representing here have excellent treatment guides. Mount Sinai, the Bateman Horn Center, and myself with PLRC and Rhythm. All three of these guys I would recommend to anybody, and I think they all tailor to slightly different, populations. And so I just want to plug that for everybody listening in case you're not familiar. Since we have about 15 minutes left, I'd love to jump to some questions if everybody's on board. But this has been such a wonderful discussion, and I've already learned so much that I'm excited to try and incorporate into my care with my doctor. So thank you all. But the first question here I love is, could continuous glucose monitoring be a useful tool for predicting or managing PEM? Have low blood glucose patterns have been studied as a possible warning sign of approaching crash, and or are there other devices that could help with predicting or managing PEM? Is anybody interested in taking a stab at this? Go ahead.
I opened my mouth.
Yeah, you open your mouth first, and you go first.
I don't know if continuous glucose monitoring would be helpful. I do know that hypoglycemia triggers symptoms, right? And glucose and oxygen are really important, especially for all your cells, right? That's the building blocks. And brain cells, especially, they're very sensitive and they do a lot of work. And so I learned this when my dad had a neurologic accident. I mean, he had a bleed and had neurologic injury, and he could not tolerate hypoglycemia the rest of his life because it brought all of his neural symptoms back. So that's interesting. That's all I have to say with my open mouth.
No, I mean, I would piggyback on that and say I think one of the things that I've learned about physiology of PEM does seem to be that lack of bioavailability of nutrients and building blocks of energy make it worse, or make it more likely that you're going to go into a crash. And so, although I wouldn't say that continuous glucose monitoring strikes me as like the be all and end all of biomarkers of PEM, it absolutely, if you're going into a hypoglycemic crash, I would be very worried about, triggering PEM. In terms of continuous monitoring, I'm holding a candle for continuous lactate monitoring. I know that there's more than one company working on it for various reasons that, various other, non-long COVID, non-ME/CFS reasons that people would want lactate monitoring going on. Not least of which, like athletic performance, which is great for all of us because that means that someone will probably do it and do it right because there's a lot of money in it. But I think that could be actually a really good way of helping to pace.
Love that. Dr. Curtin, anything else you'd like to add on this?
Yeah, I think the CGMs, mind you, some of the CGMs are not as good at picking up hypoglycemia as they are picking up hyperglycemia. So you have to really make sure which one you're using, like look at the tolerances on them. Like for instance, they've got different ranges depending on if you're using like the kind of like consumer available device versus the one that was designed for like type 1 diabetes. And so one thing I agree with everything everyone said is the hypoglycemia can be an issue. I have caught some people with, who were very unexpected to have very elevated blood glucose. And to me, that kind of pointed to they have some degree of insulin resistance. And so that was, I was kind of looking at, okay, maybe that may push me to try treatments in the category of things like a low dose of metformin, maybe a low dose of a GLP-1 to try and get the glucose into their cells, reduce insulin resistance. The other thing that sometimes shows up, especially if you have symptoms after eating, is reactive hypoglycemia. I personally had that. And that one can be rough. It's not always necessarily like a PEM thing per se. But if you're finding that you're really crashing out pretty hard a certain amount of time after eating, that would definitely be something to look into. But again, you got to make sure it's the right glucometer and always check when you have an extreme value using a CGM, you want to check with a finger prick device because sometimes the CGMs, especially some of the consumer grade devices can be off by a significant fraction. So you always want to confirm any really high or really low readings with a finger prick. I agree with the lactate monitoring. I think that's very, very exciting. There's also some devices. There's one, I can't remember the name of it, but it like measures kind of like oxygen perfusion. It's like a NIRS spectroscopy device that measures it in muscle. It's mainly designed for athletes, but that could be a really interesting one. I think Renegade is working on using that in some testing they're doing. But there's some really fascinating devices. And I think a lot of people have been using wearables to look at things like their HRV in the morning. Sometimes they find that if their HRV is particularly low that morning or lower than usual, they may have a lower energy envelope that day. Or let's say their resting heart rate is higher when they wake up that day than their usual. That may also mean that your crash threshold, you got to watch more closely that day.
Great. Dr. Bateman.
I just wanted to add a comment, and maybe we can use glucose as an example, that there are lots of things that we probably would benefit from supplementing, but that more is not always better, right? Your body does things in very small amounts. And I think mega dosing of things can be toxic. So, I mean, let's just use glucose for an example. Either low or too high are damaging. Same with oxygen, right? Either low or way too high, not the kind you get with nasal cannula, but oxygen in high concentrations can be toxic to your lungs.
Right.
And there are certain nutrients that can be toxic if you take too much. So I think it's really important not to just pile on dozens and dozens of things, but to test them out carefully and then make sure that you're taking them in doses that are not toxic for you.
Great advice. Let's move to the next question here. And we've kind of touched on this a little bit, but I think it's great to put, to cross our T and dot our I on this one is how can we identify triggers or determine our baseline when PEM can be delayed by hours or even days? Why do some activities trigger PEM inconsistently while others episodes seem to occur for no apparent reason? Does anybody have, this is something we all struggle with all the time. I struggle with it. I do something and then 2 days later, I'm not feeling well and I have no idea how to trace it back. Any tips, tricks for how to tune into more of our triggers and how we can string them back? Dr. Bateman, you said you used to brag about this, about being able to pick this up. So I'm gonna go to you first again.
Yeah, I mean, I have an advantage when I'm sitting down with a patient, right, and asking them questions. Well, what about this? What about this? What did you do 48 hours ago? What did you eat? Who did you see? Where did you go? Right? And I can help talk people through it. It's harder when you have brain fog and when you're sick, right? But
do you like that timeline, 48 hours?
Well, I'm just thinking about the delay in PEM,
Right.
And that's a little different, right? But trying to think back about what happened if someone's crashes as PEM on Monday, what were the things that happened on Friday, Saturday, and Sunday, and try to look through all those triggers and piecing them together.
Right.
And I had someone who's in a POTS crash that I talked to today, and she was pretty sure it was a new medicine she started, but once we got talking, she'd had a viral infection and had an immunization that both I think could have been triggers with some delayed response and things that were typically, this isn't PEM, but it's POTS. But it's hard. It's like trying to figure out what you're allergic to, right? And it's hard to keep a perfect record. But the best way to do it is to kind of keep a record of your activities and back, if you can. And maybe just in a calendar, the kind of things, log in what you do and what you eat. Now, you don't want to get it so detailed that it's, another cause of PEM. But it's really about the look back period, right? And seeing if you can figure out what added up, the things that added up.
I like that. I'm gonna go do our next question here. How can someone distinguish fatigue caused by POTS from post-exertional malaise? Does David, earlier you were harking on making sure we get PEM right and our criteria right, so I'm going to go to you on this one.
Thanks.
Yeah.
Yeah, no, I mean it's tough, and I do think the cop out answer is working with clinicians who understand it and who are helping you to do tilt table testing and understand what your current sort of autonomic situation is versus what your sort of energetic and metabolic situation may be. In addition, something that we've spoken about quite a bit is what is your trigger, right? So is being upright something that is causing you to experience a lot of extreme fatigue and a lot of sort of crash like experiences and behaviors. I'll also say something that is slightly controversial. But what I will say is in most cases, this is not always the case, but in most cases, if you're experiencing fatigue or crashes from POTS, it's much easier to relieve those fatigues, that fatigue and those crashes by laying down for a brief period of time, experiencing some rest, hydrating like a maniac, getting a lot of sodium on board and a lot of fluid on board. It's not to say that POTS can't really severely debilitate you for weeks. It's just to say that more frequently POTS can be quickly resolved. A POTS flare can be quickly resolved, whereas a PEM crash can be harder to get yourself out of.
Great. I have another question here. I'm not sure. This may be our last question with time here, but I think this is a good one. So say I'm going to summarize because they wrote it a little long, but say somebody has been pacing for years, they're not crashing anymore, but they're also not exercising. And they're not sure if they're improving, and they're not sure whether they're at a point where they should reintroduce any exercise. Any advice on how a patient should manage this, where they have mastered pacing, they're not crashing, but they're not improving, and they're also not exercising, but they're curious about trying to introduce more activity, maybe not just exercise. Jen, can I go to you on this one, and then maybe we can do some cleanup? Any thoughts on this?
Yeah, I think I think generally it's sort of like testing things very, very carefully in very tiny, tiny increments. And being very controlled about it. Like it sounds like whoever this is very disciplined and has really mastered pacing. And so presumably the discipline would still apply to trying additional things. And again, I always say if you're going to try something new, whether that's a treatment, whether that's slightly more activity than you've done previously to test your energy envelope window, always do it ahead of a time where if you do crash, you can rest. So like don't do it before a work interview. Don't do it before you have to, basically be, taking care of a bunch of the kids from your neighborhood. Don't do something like right before you really need to be functional. Always do it if it's like a weekend where you have nothing going on, and if need be, you can just rest in bed that whole weekend. That's when I would time it. But if you kind of know what your threshold is, it would be like picking something that's maybe even just 5% more than what you do, maybe even less, and doing it for a very short amount of time and logging very carefully, like as Cindy said, like in a, a little calendar. You can even log it in something like, like an app or anything like that. But to track it and then only do something like maybe a couple minutes of it at that slightly increased exertional threshold. And then stop, don't do any more. Stay within your pacing threshold for the rest of that time. And then monitor yourself for the next several days and see, do I start feeling worse symptoms? Do I get a baby PEM crash? And if you do, then you know that was even too much. But if you don't, then that's something where you can kind of try that threshold again, make sure it wasn't just false signal, and just do that tiny interval increase amount again. And if you don't crash again, then you can consider increasing by maybe another 5% the next time. So it's like tiny baby steps and really, really monitoring yourself and tracking closely so that you know, hey, did this have a negative impact on me or not? And if you hit a point where it does have a negative impact, that's where you kind of know your new threshold is. And you just need to step a little bit below that.
Great. Well, I'd like to wrap up here with just any general thoughts, closing remarks on the topic from folks since we're at time. And I just want to thank again all three of you for joining us with your very busy schedules and shining so much wisdom and giving us a lot of hope for dealing with this incredibly debilitating and quite frankly miserable, symptom and condition. And so, yeah, why don't we go to Dr. Putrino? You can either pick up where Jen left off, or if you just have any other thoughts that you want to share with everybody else here today.
No, I mean, really grateful to be here. I learned a lot, so I hope that everyone else learned a lot. And I think that we're really learning a lot about the underlying pathobiology. So I hope that everyone just can keep the faith and understand that we're getting closer to treatments.
Great. Dr. Bateman.
I would just say, don't give up, right? The people who do the best over time are the people who try to stay positive and proactive, and try to find meaning in the place where you are, and appreciate, I don't know, just try to be patient. I mean, it's hard to say because it's awful, right? And it can be, and I get that, right? But I do think that finding meaning and trying to stay positive are really important things to improve your brain biochemistry, almost as much as medication.
Great advice. Dr. Curtin, why don't you finish this off here?
Yeah, I'd just like to thank everyone, all the panelists, Charlie, excellent job moderating, and everyone here who attended. I know your energy is scarce and limited, so thank you for spending it with us here. We're going to be posting this to YouTube afterwards, so if you had to drop off early or if you want to share this with someone, it'll be on YouTube in probably the next couple of days. But yeah, I echo the same sentiment as Cindy. I lived through PEM. The symptom is hell. It's horrible. And it's even hard to describe to other people who haven't experienced it because it's just so, like, you just kind of can't fathom it unless you've lived through it. And it's just awful. And my heart goes out to every single one of you who's experiencing this. And, I'm really super excited. I mean, David, about the mitochondrial transplant. There's some really interesting things going around about also, we've got a couple of patients who are going to be doing stem cell reeducation therapy through compassionate use. There's interesting things that are going through trials. Ferion's got a really interesting device. They have an open label study going on that seems to improve mitochondrial function non-invasively using magnetic fields that are pulsed. And I'm just like so excited about the things that are changing, and the things that are coming out in this area at a clip that I haven't seen in my entire career. Now, mind you, I've been in this for probably about 10 years at this point, but just I feel like there's so much more coming out in this area than I've ever seen that it's really hopeful to me. And I just want to say, hang in there, guys, hang in there.
Great. That's a great place to leave off. And so we'll wrap up. Thank you, everybody, for joining. We will share the recording after. And thanks again to all our panelists. Take care.